Folks, we'll go ahead and get started. I'm Conrad Lyles, the Vice Chair in the Department of Medicine, and I'm pleased to announce that today's Medicine Grand Rounds is the annual Kirby Lecture. And the annual Kirby Lecture was established back in 1986 or 1987, and I think that this will be the 38th Kirby Lecture, if my math is correct. And it was established, or the first Kirby Lecture was in 1987. And it's an annual lecture to honor Dr. Bill Kirby and his legacy in the field of infectious diseases. Dr. Kirby was the founder and division head of the Division of Infectious Diseases at the University of Washington, which was founded in 1949. So he came on, he was division head all the way for about 25 plus years. And initially his research was primarily in early antimicrobial research, antibiotic research. You can imagine in 1949, there weren't a lot of antibiotics available at that time. And so he was on the cusp of those emerging development of antimicrobials or antibiotics to treat infectious diseases. Later in his career, he was primarily or best known for development of standardized methods for antibiotic susceptibility testing for bacteria. And each year, the Division of Infectious Diseases or Allergy Infectious Diseases invites an international, national expert in infectious diseases, an investigator, to come and give the annual Kirby Lecture. And to introduce this year's lecture, I'll turn it over to Dr. Anna Wald, the Division Head of Infectious Diseases.
Thank you, Conrad, and everybody. So it gives me great pleasure to introduce this year's speaker, Dr. Yonatan Grad, who received his undergraduate degree from Johns Hopkins, subsequently obtained a master's in philosophy at Cambridge, and then his MD and PhD in genetics at Harvard Medical School. He completed his clinical training in internal medicine at Brigham and Women's and in infectious diseases in the combined Mass General and Brigham program. Dr. Yonatan Grad is professor of immunology and infectious diseases at the Harvard T.H. Chan School of Public Health. His research seeks to understand how we best prepare for and respond to infectious disease threats and how our clinical and public health interventions in turn shape pathogen ecology and evolution. He addresses these questions using interdisciplinary methods, including molecular biology, pathogen genomics, mathematical modeling, and epidemiology. He teaches modeling of diseases at Harvard University and has worked closely with the CDC as well as the WHO, addressing the issues of antibacterial resistance, especially in Neisseria gonorrhea. And today he will tell us about antimicrobial use and resistance. What can we do better? So welcome.
Thank you so much for the lovely introduction and the incredible invitation to be here. I am totally honored. It is really exciting, and it's been a wonderful visit so far, seeing old friends and colleagues, and having a wonderful time talking science. So I wanted to begin actually honoring Dr. Kirby with this paper from JAMA in sorry, just gonna address how to nope, can't hear. Let's see. Okay. Auspicious beginning. Can you hear me?
Sorry. Okay, sorry. Sorry. There we are. Okay. Can you grab my laptop really quickly?
Not that mic.
Oh, I know.
This one.
I know, but I'm trying to turn this one off so that it doesn't have dual.
Yeah. Can people hear me online? Yep, better. Okay. Great. Thank you. Sorry about that, folks. There we go. Okay, so getting back to this, as I was mentioning, there's this great paper from Bill Kirby. So picking up on, as you mentioned, what the antibiotics available back in 1949, 1950. Here's a paper on recent trends in antibiotic therapy. These were the drugs reviewed. How nice to take the boards at this time, right? Sulfonamides, penicillin, streptomycin, aureomycin, terramycin, which are oxytetracycline and chlorotetracycline, so basically the same class of antibiotic, and chloramphenicol. So you've got 6 drugs and 5 drug classes. This is what was available at the time. Where are we 75 years later? So this is just a partial list of available drug classes in the left side of each column, and then examples from each of those drug classes. And keep in mind that although these are individual examples from a number of these drug classes, there are dozens or scores of examples, right? So we've got a whole lot more antibiotics, much tougher for the boards, right? So how do we get here? Why are we here? Well, this is in part because of drug resistance, right? So as we see resistance emerge, we need new drugs to treat these pathogens. So let me give you one example. As Anna mentioned, one of my favorite organisms is Neisseria gonorrhoeae, the cause of the sexually transmitted disease gonorrhea. And here we see examples of recent papers talking about the emergence of ceftriaxone-resistant Neisseria gonorrhoeae, which we're seeing appear in the UK, and even in my home state now of Massachusetts, where there have been 2 cases of non-susceptible Neisseria gonorrhoeae. Okay, so what do we not want to go back to? Well, these are examples of what treatment of gonorrhea was like in the pre-antibiotic era. So over here we have Dr. Reed's Eureka tonic. What was it? Well, first it was to treat syphilaria, a nice portmanteau of syphilis and gonorrhea. And it was dilute mixture of cocaine in alcohol, right? So it may not cure you, but it'll make you feel better. I also feel like Dr. Reed would not be out of place in HHS today. And then over here, we have a urethral irrigation system, which where caustic compounds like potassium permanganate were used for urethral irrigation, right? So in this case, it also may not cure you, but it'll definitely make you feel bad. My favorite example of bench to bedside learning here is another paper from JAMA in 1935, fever therapy for gonococcic infections. So for those of you who want to read the small print, you can see that down in the corner, they talk about how bacteriologists know that Neisseria gonorrhoeae does not grow at 40 Celsius. And so they had this great idea of like, okay, heat up the patient, right? And it actually seemed to work pretty well. I will save you from the images of subsequent engineering innovation where people thought, why do we have to heat up the whole patient? Okay, but this issue of emerging resistance and then the need for new drugs continues, and I wanted to just highlight a couple of recent developments. One that was just announced at ASTMH, the American Society for Tropical Medicine and Hygiene last month. There's a clinical trials for a new drug for malaria, desperately needed as we're starting to see artemisinin resistance. In fact, just today, the WHO had a report on growing resistance to artemisinin compounds. So we need new therapy still, and this armamentarium is continuing to grow. And then down at the bottom, a report on a new drug, gepotidacin, for treatment of gonorrhea, and we'll get back to that one a little bit later. So the topic I want to try to get into a little bit is this question of, can we slow, control, or even reverse drug resistance? How can we do what we do better? And then what are the challenges we face as we try to answer this question? So I think of antimicrobial resistance really as an ecological and evolutionary phenomenon. And I'll take you through this here. And you can tell we're in the realm of theory because people are circles and pathogens are smaller circles, right? So imagine here you have someone who has an infection that is drug susceptible, is represented by green. They have treatment failure with the emergence of resistance, which is going to be red. Right? So we think of this often as when we care for our patients, what happens within an individual. But of course, bugs transmit, right? So we can then imagine these resistant strains going off and colonizing other people, and you get the spread of resistance in a population. We often think, though, that there's competition between the resistant and the susceptible strains, right? And resistance often incurs a fitness cost, where if you were to compete the resistant strain against its susceptible counterpart in the absence of the drug, the susceptible bug would be more fit and would outcompete the resistant one. And so you can imagine situations like this where you have someone who has treatment eradication, you open a niche, and then you can see spread of the resistant bugs in the presence of the drug, but in the absence, it's the susceptible strains that might spread. And this ecological dynamic is one that is, I think, super interesting and important as we consider how we approach this general problem. And this will come up a number of times in the talk. But I would argue that we lack really systematic understanding of the selective pressures driving resistance, right? So we want to have an understanding of what are the pressures, and we want to have an understanding of how much resistance is out there. I'll give 3 examples of ways in which we don't have good understanding. The first is some medications have antibiotic activity, including ones that we don't really think of as antibiotics. The first in this category, just pulling out 3, thiazide diuretics. Where did thiazide diuretics come from? It came from sulfanilamide, right? These are sulfa drugs. In my first year of medical school, I remember my pathology professor said that all drugs should be thought of as poisons with beneficial side effects, right? Emphasizing the concept that many of these drugs have off-target effects. And then, the drug developers and chemists think about how to adapt and develop those side effects if they look like they may have some kind of benefit. So to the extent that these early sulfa drugs also had some capacity as a diuretic, that chemistry was then developed, and you end up with thiazides. They still have some antibiotic activity, right? It's now a secondary activity, and it's much smaller, but there's still some. Sirolimus, rapamycin, we think of it really as an immunomodulatory agent, immunosuppressive, but it was actually found in a screen for antifungals. And then, crazily enough, statins actually have not very much, but they do have some antibacterial activity. So as we think about the pressures that are shaping the microbes that live in us and on us, and all the different medications that people take, we have to be aware that there are these pressures out there that we don't normally even consider when we think about our antibiotic use. And that idea of the bugs that are on us and in us leads to this notion of bystander selection. So really, whenever you take an antibiotic, so you're taking penicillin for strep throat, you're exposing all of these bugs to penicillin. It's not just targeting the strep pyogenes causing the pharyngitis, right? So you've got Staph aureus on the skin and in your nose, and you've got strep pneumo, H. flu, and Neisseria meningitis hanging out in the naso and oropharynx, all these gram-negative rods and enterococcus hanging out in your gut. They all get exposed. So one question we were interested in was how much of the drug exposure experienced by these bacteria is due to infections that they cause versus due to infections caused by something else, right? So this is the proportion of antibiotic exposures in a species that are due to treatments they did not trigger. So our way of looking at this was to first ask what antibiotics are used for which infections and how much, which bacteria cause those infections, and then what is the carriage prevalence of these bacteria, right? And then with really straightforward arithmetic, we can come up with a proportion. And here we can see that most antibiotic exposure that these bacteria experience is actually as a bystander. I mean, almost entirely, right? Strep pyogenes perhaps is the smallest, but there's a huge amount of this bystander selection. What this suggests is not only do we need to think about bringing down individual use, you need to think about bringing down the use overall. Okay, but what really is our use? I would argue that we don't have a clear understanding of the amount of antibiotics even used in people, and I'll take you through a little bit of this here. Okay, so you can think back for yourselves individually, what's your antibiotic use? And I'll ask, since we have people here in the audience, what fraction of the population do you think has had at least one antibiotic, outpatient setting, at least one antibiotic fill in a year? Bunch of ID docs in the audience. Okay, so the answer is it's around a third of the population has at least one, and by year 4, it's around 2/3 of the population. Most of that is penicillins and macrolides, and then you see a variety of these other drugs. So here we broke it down by a variety of categories, and I have not put labels on it because I'm going to ask you guys again. Okay, one. Who uses more antibiotics, men or women, and why? Okay, so unsurprisingly, people got it right. It's women, and it's because of UTIs. If you account for UTIs, that line collapses into the line below. It looks exactly the same. Often when I ask this question, the other answer I get is women because they're more likely to seek care, and this is the old medical adage, women get sick, men die. Right? So there's a behavioral thought that often people have in addition to a biological one. US Census regions, there are 4. There's the Northeast, the South, the Midwest, and the West. One of them uses more than the others. Why? Right, so I get different answers here too often. Northeast people think, oh, there are a lot of doctors there and so on. But in fact, South, which everyone here said, so kudos, is right. And the why is really interesting. Some people are saying access to care or something. We know that in the South, there's more cardiovascular disease, there's more obesity, there's more diabetes. Could it be that there's actually more infectious disease, that all of these are actually warranted? Or is it something else going on? Is there some behavioral issue? Age group, I'll give this one to you, it's little kids. So we looked at what was happening in Massachusetts, and here are data basically playing, as you can see, month by month for prescribing. And in Massachusetts, you get the same range that you see across the US. There are some areas that have little antibiotic use, you have other areas with a lot, and you can see just how seasonal it is, right? You get these peaks in the winter and then naders going in the summers. So we wanted to dig into this question about what explains the geographic variation. And so we used market scan data, which is a collection of insurance claims data from employer-based insurance. And here the circles represent major metropolitan areas. Right? And what we plot here for sinusitis, otitis media, other respiratory infections, and strep pharyngitis are the visits per people and the prescriptions per visit. So we basically break this down thinking that what we can divide is this notion of burden of disease, perhaps, as a proxy, number of visits, right? And the prescribing per visits is a sense of stewardship, right? How well do people do? Do they prescribe when people come in or not, right? And then the colors indicate the census region for those major metropolitan areas. So if you take this example for sinusitis, what you see is that the prescriptions per visit are basically the same everywhere. You come in with sinusitis, doesn't matter where you come in, you have the equal likelihood of getting an antibiotic. But the visits change, right? So why that is that because of burden of disease or is that because of something else? I don't know. But I think it's a super interesting thing. You can see that for sinusitis, for otitis media, for strep pharyngitis. For other URI, you definitely have differences as well in terms of rates of prescribing, with more prescribing going on in the South, more likelihood of getting a prescription. One of the other questions that I was really interested in, and this really was a question that I had as a fellow when I was writing all of these prescriptions, particularly for people who had infected prostheses, for example, and were on just suppressive antibiotics, or people who had chronic UTIs. There were some people who had a lot more antibiotic use than others. And so we basically looked at the Gini coefficient, right, the cumulative antibiotic use, cumulative population, to get a sense of how intense the use is. And what we found was 10% of the population in the outpatient setting used 57% of the antibiotics. This then led us to ask another question that I've been wondering about. If you were like the czar of antibiotic use and you could reduce use, would you rather reduce its breadth or its intensity? Right? Meaning the number of people using antibiotics, or kind of bring it down from the people who were using the most. Kind of think of it like, if you had a hermit off in the woods, you kind of subsisted on meals of antibiotics, right? Now, people who just had zithromycin for breakfast and penicillin for lunch and so on, like would you rather take away one of those meals, or was like someone who snacks occasionally on azithromycin, right? Which one would have, on a population level, the biggest impact? So in this analysis, what we found was it was actually breadth that associated more with use than intensity, right? So trying to reduce overall use, of course, we want to do, but bringing it down wherever we can, we expect by association, wasn't causal, but by association would have the biggest impact on resistance. Okay, this was all using data from the US and all in the outpatient setting. We actually have almost no visibility into what the intensity of use is in hospitals. They don't share data. Right? It's very, very hard to get. And in the rest of the world, it's almost impossible. And that's because there's so much availability of drugs just over the counter. One of my postdocs went on holiday to the Dominican Republic, and he sent me this photograph from the pharmacy in the airport. Viagra, Cialis, ampicillin, and azithromycin. Go have a fun vacation. Stay healthy. Right? We really don't know what's going on in much of the world. Looking back at the US, what has been happening? What are the trends? How well are we doing? We know we have to reduce use. So there's a study from Blue Cross Blue Shield that actually saw use was dropping over this time period up through about 2017 in the US. And when we looked at this in Massachusetts, we saw about the same decline. And we're really interested in what's doing it. Is it improved stewardship, or is it less use for other reasons? So what we saw was that most of the drop was in wintertime pediatric prescribing. Okay. And then when we broke it down by indication, we saw was things like bacterial infection, miscellaneous bacterial infections, gastrointestinal infections, skin, soft tissue infections, all of those stayed the same. Suppurative otitis media, sinusitis, bronchitis, bronchiolitis, all of those went down. Okay, and then we could look at a variety of these conditions and compare what was the improvement in terms of, again, thinking about this in terms of visits versus per visit prescribing. Most of the gains were due to fewer visits. There was some improvement in prescribing, right? So less prescribing, but when not indicated, but most of the gains was actually just fewer visits, suggesting reductions in disease. When we looked at this in NAMC, so a national database, this decline that we observed really started in 2010 and was seen across the US for antibiotic meriting conditions, whereas all other conditions basically stayed the same. So what happened in 2010? Now, here's one possibility, but the other one that we thought it was rollout of PCV13, right? Pneumococcal conjugate vaccine for kids. And we know that it had a remarkable impact on invasive pneumococcal disease, right? So this is data from a CDC report that basically really brought down hospitalizations due to pneumococcus. And if that is what happened with severe disease, our inference was that it was also having a big impact on outpatient disease, and why we're seeing a decline in sinusitis and otitis media, things often associated with pneumococcus. Okay, vaccines can prevent infections, right? And it has multiple impacts, right? Not only is it preventing this disease, it's preventing the use of antibiotics, right? And then pressure driving resistance. And it's not just bacterial infections with those kinds of vaccines, even vaccines for viruses, because we know people prescribe antibiotics when they're not indicated, inappropriate prescribing for flu. Sometimes it's appropriate when people have superinfections, but for the most cases it's not. And this is a study out of Ontario that basically showed with an increase in flu vaccination, they saw decreases in antibiotic prescribing, right? Okay. Disease prevention reduces the use of antibiotics and selective pressure is driving resistance. Okay, but what are we seeing in terms of antibiotic resistance trends in the US. So this is data from a study we did together with colleagues at the University of Utah. We had access to the VA data. So this is all from around 130 different VA centers from around the country. And we looked at, this is just a couple of the bugs. We looked at Staph aureus and Ephesium, looking at methicillin and vancomycin. So in blue, we have those that are susceptible, so it would be MSSA, in resistant, so MRSA in red, and then data that we're missing in gray. And then the bar chart gives us our resistance proportions, so what fraction of the overall population is actually resistant. What you can see is the resistance is not inevitable, and the rise in resistance is not inexorable. There are ways that things can go down. Why is it going down? We're not entirely sure, but I would guess it's a combination of changes in prescribing and infection control efforts that block transmission, right? So we're seeing it both in hospital-associated infections on the right and community onset infections on the left. And you see the same for Ephesium up until something happened in 2020 where practice may have changed a little bit, right? And then we see, with COVID, more drug use, it seems like more antibiotic use, and so that may be reflected here in rise in resistance. But this relationship we can show very clearly for things like fluoroquinolone. So we know fluoroquinolone use has really declined, as you can see here. And then across a variety of organisms, gram-positives, gram-negatives, Staph, Pseudomonas, Acinetobacter. The red, again, is resistance, right? You can see how those have gone down. So this gets back to this ecological phenomenon, right? If you reduce the selective pressures, you actually see reductions in the resistant strains because they're less fit, right? So this is in keeping totally with that ecological theory. Think back to those circles, right? Okay. That said, these are all cultured specimens, and our understanding really of antibiotic resistance in a population is limited, right? We have to rely on those samples that we're able to get from people and they get tested in the lab, and it's a fairly limited set. We rarely have systemic surveillance systems or systematic surveillance systems, and we don't really have information on colonizing prevalence and dynamics in individuals and in populations, right? So we're working here with limited data as we try to understand this use-resistance relationship. We need better information for use. We need better information for resistance in order to really think about what are these factors and where can we best intervene. So people talk about the antimicrobial pipeline being dry, and it certainly is at a trickle compared to things like oncology, but where are we? So the WHO recently put out its list of the distribution of species-specific programs, their bacterial priority pathogens list, those that are critical, high, and medium, and what I'll do is just highlight a few here by the species. So for Pseudomonas, there are 22 species-specific products that are in either preclinical or clinical trials. For TB, quite a few, 21. Staph aureus 8, Neisseria gonorrhoeae 8, and Acinetobacter 7, right? So there are actually drugs in the pipeline, and I would suggest, and as we'll get into, there's a question of how do we best use them. Not only are there these kind of more traditional therapies, antibiotics being developed, but there are lots of non-traditional approaches that people are now developing. Antibodies, antivirulence factors, bacteriophage, immunomodulating drugs, microbiome modulating drugs. So there are lots of different approaches that will require efforts to think about how do we best use them? Okay, so for this question, I'm going to tell you about some of the work that we've been doing thinking about this for Neisseria gonorrhoeae. So there are 2 new drugs, each first-in-class antibiotics that have been developed, and each have gone through phase 3 trials that were reported this year. One, zoliflodacin. It was developed first by Entasis, that got bought by Innoviva Specialty Therapeutics. Grad, which is a nonprofit based in Geneva dedicated to making drugs available for low and middle income countries, paid for the phase 3 trials so they could have distribution rights in LMICs. It's a single dose, oral, and it's just for gonorrhea, right? So it helps to address this question of bystander selection that we talked about earlier. Gepotidacin, also first in class, developed by GSK. It's 2 doses, 10 to 12 hours apart. That happened because in the phase 2 trial, when they just had a single dose, they had 3 cases of failure out of 69 people. 2 of those, they had demonstrated emergence of resistance on treatment. And so they switched to a 2-dose regimen with the idea that that would help block emergence of resistance. And in the phase 2 trial, there was no resistance no reported. So it seemed like it's working. Also an oral regimen. And here it's not just for gonorrhea, but actually also for UTIs. Its UTI indication was already approved by the FDA. Both of these are up for approval later this month, coming up mid-December. So we used a mathematical modeling approach to ask, what's the best way to roll them out? The traditional approach for gonorrhea is to use one drug, and then when resistance hits a threshold of around 5%, you say, you know what, because we're treating empirically, that's a failure rate. Beyond that, we just can't tolerate, so we'll switch to another drug. So it's this notion of sequential rollout. The alternative is to have basically free access, just whatever the drugs are out there, make everything available, or what we call, in this case, we just use equal allocation. So really just having all the drugs available for people to use and think about them being used equally. So in this case, it would be ceftriaxone, which is the current standard of care and the current last remaining antibiotic. But imagine if you could use ceftriaxone, gepotidacin, or zoliflodacin. By distributing the selective pressures, you basically slow the emergence of resistance and extend the clinically useful lifespan for all 3 drugs, right? Basic kind of ecological concept, and here we're able to show it as well. That's under the assumption that the mechanisms of resistance to each of the drugs is independent from each other. Okay, are they? So gepotidacin and zoliflodacin are first in class, but they both target topoisomerases. So the topoisomerases, we've got 2 different complexes. There's gyre A, gyre B, the gyrases, and then par C, par E. Fluoroquinolones also target these. So we have CYP for ciprofloxacin, Gepo for gepotidacin, Zoli for zoliflodacin. And then I listed here the different resistance mutations, but the one to keep in mind for gepotidacin, gyre A, A92T confers resistance to gepotidacin in the background of this par C D86N. And Zoli resistance is through this D429N mutation. So we were really interested in thinking about, okay, if the zoliflodacin, which is going to be rolled out by Grad P in low and middle income countries, is likely the one that's going to go to places in the world where ceftriaxone is at risk. And the biggest place that is right now is East Asia. We're already seeing ceftriaxone resistance levels, high MICs. 20–30% of the population is reported in some parts of China, out of Hanoi, and in Cambodia. So we think Zoli will probably be rolled out there first. What we did was to take strains representing those dominant lineages circulating in Asia and put in the Zoli resistance mutation to ask how well do those resistant strains compete against their susceptible parents to get an understanding of what do we expect to happen with these lineages and have a good understanding of what to anticipate. What are those strains also resistant to and so on, which help us prepare. When we did that, we came across something that really surprised me. So here are just 2 examples. These are 2 strains out of the 10, the most important ones, because when we put in the zoliflodacin resistance mutation, sure, we saw Zoli resistance go up substantially, but so too did gepotidacin resistance. So these drugs, each first in class, each developed totally independently, but targeting topoisomerases in the right background, a single point mutation can actually confer cross resistance, right? So raises concern that rolling out one, particularly in this part of the world where we think we know what the genetic background is that's relevant, and it's pretty high in this part of the world, is concerned that these drugs might not be quite as independent as we had hoped. And you can see this here in this model of the gyre A, gyre B heterodimer. When we focus here on this A92T, which we know confers resistance to gepotidacin, and the D429, which is the site that confers resistance to Zoli. But you can see they're just right next to each other. So in the right background, this mutation seems to have the same effect as a mutation in A92T. Right, so these drugs may not be quite as independent of one another as we may have thought. Okay, so then there's this story of bedaquiline. So another first-in-class antibiotic, really the first TB drug in a long time, right? And an amazing thing. Clinical trials completed in 2011, FDA approval in 2012, and then we see approval from the European Medicines Agency in 2014. Challenging access, right? Because of course, when things are first available, it's tough to get them out, right? And there are limited supplies and so on. And what were they used for, right? So bedaquiline was used in people who were otherwise failing therapy as salvage. Well, okay, why do we treat TB with multiple drugs? Because we know if you use monotherapy, there'll be emergence of resistance. Using bedaquiline in the background of just, drugs that we know are failing, multi-drug resistant strains, essentially you're getting bedaquiline monotherapy. And what we saw was emergence of resistance. Now bedaquiline is broadly available. It's used as part of this BPAL regimen. And then what's happened with resistance in places particularly where the trials took place? So if you look at South Africa from 2019 to 2023, of those that are rifampicin resistant, right, the TB strains that already carry some resistance, 3.6 to 10.2% are bedaquiline resistant now, right? And in Mozambique, the prevalence of genotypic bedaquiline resistance, so this is where there's a known resistance mutation, you can just look for it. In Mozambique, it's increased from 3% to 14% from 2016 to 2021, right? So what we're seeing is now emergence of substantial amounts of resistance to bedaquiline. How has the TB community responded to this? What we see in the TB Alliance argue is that instead of developing individual drugs, now they're drug regimens, right? So I mentioned before that 20 some odd drugs that are being developed for MTB. Instead of thinking of them as individual drugs, there's work both in the preclinical stages and then thinking about it clinically of which drugs are going to pair best. Think about it in terms of toxicity, think about it in terms of synergy. But instead of rolling out just one drug at a time, you think about rolling out drug regimens of the most optimally paired sets of drugs. And that goes through from beginning all the way through clinical trials. And so it sets up the regimens that will be used in clinical settings. So, this has the advantage of each of these drugs protecting the other, right? Two new drugs, as long, again, as their mechanisms of resistance are independent and are non-overlapping with existing resistance mutations. Right? So it's an innovation in how to do this. And it's driven in part by the funders, of course, but also the pharmaceutical companies get on board. And you can understand why they would want to. Right? This is an opportunity for their drugs to be longer lasting, right, and have contexts for use. Okay, so it raises this challenging question of how do we coordinate across preclinical and clinical development to devise optimal strategies for drug development and rollout. And I certainly do not have an answer for this. I don't know how we, in this current context, are going to be able to do anything to control the interface with private industry. But if we could, you could imagine that this is the kind of thing that would be ideal. Going back to that set of drugs that we were rolling out. Okay, so. It looks like I've gone through this quite quickly, so we'll have ample time for questions. But clearly, we need more data on antibiotic use and resistance, how we are using antibiotics both here in the US and globally, what are the trends in resistance. We need to prevent the conditions that prompt antibiotics. So, of course, vaccines work really well. I think this is also something to keep in mind. In much of the world, there's lack of access to clean water and sanitation. Right? And if you look at cholera and typhoid, in the same way that we don't see them here because we have access to clean water and sanitation, we could make a choice as a global community to get rid of these pathogens really by providing basic necessities to people around the world. Right? And it is a moral choice that we make. And as we see drug-resistant typhoid pan-drug-resistant typhoid as a concern, it's something to keep in mind. Then we really need to improve our understanding of the selective pressures driving resistance to help optimize our interventions and devise strategies for how best to introduce and use our new therapeutics. I think it's time to really revisit these strategies where we just roll them out as they come, as they are developed, and instead think carefully about how best to use them. Okay, so with that, I will, for those of you who are on Zoom, give you your time back or welcome questions, but happy to field questions from people here.
Well, thank you very much for that excellent talk. It was both informative and entertaining, I would say, and energetic. So thank you very much. And for those out and remotely, please put your questions in the chat. We'll take some questions in here, but the ones on the chat will be monitored by by one of our chief residents, who will then pose those questions after we have some first ones here. We'll start here.
Yeah, great talk. Just interested how you're using AI in your research, and maybe any tips for researchers or any pitfalls you've encountered.
Okay. We have been involved in one project to develop new antibiotics using AI. So this is a project led by Jim Collins and his group at MIT. And they're come up with a few new antibiotics for Neisseria gonorrhea that we're actually pretty excited about, that look pretty good. So I think there's an opportunity using generative AI to think about new therapeutics development. Other ways you can imagine using AI in this is, looking at big data sets and training models and so on. We haven't done a lot of that. We have done more classical machine learning and trying to think about what mutations are associated with what resistance and how well we can explain resistance by known mutations. And our goal there is to help inform the use of sequence-based diagnostics. So what we try to ask is, given the known set of mutations, how much of resistance can they explain? So often we use linear mixed models, but we also use AI approaches or machine learning approaches. And then use that to then inform development of sequence-based diagnostics. But really, I would say the way we've used it the most in the lab is to help people code. So I have had a few people in the group who have come in from clinical training and without much coding experience. And it has been fantastic for really helping people advance quickly in their coding. So asking for help from ChatGPT, for example, for assistance in developing code to analyze data sets. It's been most useful in that context, I would say.
That was an amazing talk. I was really struck by the regional variation in antibiotic use. And I think my immediate question, in addition to what's the difference in the population, is how much of that outpatient antibiotic use is sort of driven by what we clinicians know how we use antibiotics a lot, which is when you sort of don't have something that you can do for somebody using an antibiotic inappropriately. And I know obviously the limitations are that you use a lot of insurance data, but are you able to parse how much is sort of due to access to care in the sense of drop-in care or urgent care prescriptions versus within primary care appointments and insured appointments. That is sort of a substitution for, asthma that's out of control. So I'll just give you a Z-Pak because I can't really refer you to a pulmonologist or, many of the other things that we would do.
Yeah, it's a great question, and I don't have a good answer. First, the restriction that we've had in this is, that we haven't had access to all the data that we would like to have access to. And that's not just, yes, it's that we were looking at market scan. Medicaid would have been a fantastic data set for this as well, to really get a better picture of the whole population. For our Massachusetts data, which went up until 2016, we did have basically 98% of the population, because at that time, there was the all payers claims database, which everyone had to all insurers, including public insurers, had to share their data. So there we had a better sense. Why did that stop in 2016? Just a quick side note, there was a lawsuit by a very large multi-state insurer who said that claimed, as the basis of this lawsuit, that making state-by-state reports for their insurance claims was an undue burden. That went up to the Supreme Court, and the Supreme Court found in favor of the insurance company, and we lost the all payers claims databases. The Supreme Court said, okay, this is something that you can legislate at the federal level. That has not happened in the almost 10 years since that decision, as you might imagine. So it has been very hard to put together the full data sets since to really answer these kinds of questions. That said, all of that's outpatient. So we also don't know who's showing up at emergency rooms, right? And what's happening there. So even, when we want to get an understanding of, okay, if there are fewer visits in an outpatient setting, is that because there's less disease, or is it because people just aren't able to get to an outpatient clinic? And then you have otitis media progressing on to mastoiditis, right? Or something like that, right? And where people end up in an emergency room. We can't see it with the data that we have right now. So getting access to better data would be, I think, a really key part of trying to answer your question. But it's one that I remain extremely interested in, because it seems like, fundamental issues from access to care to burden of disease that could, if we really understood it, allow us to take better care of people. Agreed.
It seems that, can you hear it?
Yeah.
It seems that from the point of view antibiotic resistance, a lot of stewardship. We can't just go to a local drugstore without a prescription and buy antibiotics. That is not the situation elsewhere in the world. Can you talk a little bit? I mean, I feel like obviously both bugs and antimicrobial resistance crosses borders pretty easily. What efforts are being made internationally to also bring antimicrobial stewardship to countries where right now the access is just too straightforward?
I'll repeat the question. So the question was basically like, in the US, we've got antimicrobial stewardship. You need a prescription to get antibiotic. What's happening in the rest of the world with efforts to control access to antibiotics? Given that it seems pretty clear that's a big issue. As far as I am aware, not much, right? I think it's a really big question. It's a political question in many parts of the world. It's going to be a very hard one to enforce, right? A huge challenge in trying to shift people away from just being able to walk into a pharmacy and get access to what they want. A quick anecdote on this. When I was first starting in this field, working on Neisseria gonorrhea, I saw strains that had ciprofloxacin MICs of 64 or 128 micrograms per mil, where resistance is 1 microgram per mil. And I didn't understand, why did they need to be so resistant? Wouldn't just a little bit of resistance, over 1 be sufficient in clinical settings? Until I went to visit colleagues in Vietnam. And I said, well, how do you manage gonorrhea here? And they said, well, we don't have to. People go out to pharmacies, and what they do is they buy a box of ciprofloxacin. They take 1 pill, and if that doesn't do it, they'll take 2 pills. And if that doesn't do it, they'll take 4, right? I mean, it's some kind of approaches that people have, for Advil when you have or ibuprofen when you have a headache, right? But That's why we're seeing, it's that kind of use that really drives the huge resistance that we were seeing, and that, as you said, spreads globally, right? So I think this is, that kind of, the huge change that would have to happen in so many parts of the world to shift to a regulated system, I agree, is totally important and would be needed, but I think it's a tall order. At the same time, as people may know, in the UK, they've actually shifted away from requiring physician prescriptions. So now you can actually go to a pharmacist and get antibiotic. So it seems like they're not necessarily the direction, even in other parts of the world, that we would imagine.
There are a couple of questions online that we'll take now.
Yes, many praises in the chat as well. First question is, so we have no effective vaccinations for major bacterial STDs and are now using antibiotic prophylaxis. What is your view of the use of doxypep, and what do you predict in the future?
Okay, so we've worked a lot on doxypep, and I did not include it in this talk, but I am happy to talk about it. This is in some ways the home of doxypep, so I figured it's something that many of you are very familiar with. I think syphilis is a huge problem, right? And for many years, we were seeing the rise of all the bacterial STIs. Neisseria gonorrhea, chlamydia trachomatis, treponema pallidum, they're just going up and up and up. We need tools to be able to control that. And doxypep provides one of those. And we've seen, actually, interestingly, for Neisseria gonorrhea, it started to decline even before the rollout of doxypep. And I think of the rollout really as starting with the summer in 2022, when the abstract of the doxypep study came out and was first reported at the conference. Even before that, we were seeing a decline for gonorrhea, and I don't think we know why. I think there are a variety of different explanations, but it's interesting. And then for syphilis chlamydia, we've definitely seen now numbers going down, and there's good evidence that doxypep is being successful in reducing rates of syphilis and chlamydia. Less so for gonorrhea, where we have seen resistance emerge. So Matt and SO have published on this beautiful paper showing that in fact, we're starting to see a rise in resistance in Neisseria gonorrhea, and we're starting to see resistance in bystanders like Staph aureus and Strep pneumo, right? So it has, this balance of, yes, we need to address the problem of syphilis primarily, but it comes at the cost of selection for resistance. We've shown that, in fact, high-level resistance to tetracyclines and Neisseria gonorrhea are skyrocketing in the US. And I expect, given the levels of use of doxypep as we understand them now today, that we'll soon be at fixation, right? So they'll be totally, like you see in many other countries where TET-M is a plasmid-borne resistance determinant for tetracycline class antibiotics, that is at 100% in every African country that I've seen for which we have data. It is in the 80s in many places in Europe. We have had it much lower here in the US, but it is now skyrocketing, and I suspect will be at fixation pretty soon. So there's, I would say vaccines would be great. And I know there's Bexsero, which is 4C-MenB. It's a vaccine against Neisseria meningitidis serogroup B that seems to have 30-40% vaccine effectiveness in retrospective data. And there are a number of randomized controlled trials going on, including one led by Connie Cullum here. So hopefully we'll have data, and that will be very useful. But I think it's a big challenge.
It's a good segue for the next question about what are your thoughts on pre-formulated combination antibiotics for, let's say, gonorrhea to help avoid resistance?
Yeah, so I think in theory, combination antibiotics are, as I had mentioned, something that can help protect the drugs. For gonorrhea, this was in some sense tried with a combination of ceftriaxone and azithromycin. And so people say, we tried it, we saw a rise in azithromycin resistance, combination therapy doesn't work. challenge is this kind of combination therapy is not the same thing as what we see with TB. With TB, we have multiple drugs for a very long time, right? TB therapy, many months. Gonorrhea dosing is one dose, right? So you get ceftriaxone plus azithromycin. The issue is, one issue is that ceftriaxone, even though we think of it as a drug that has a long half-life, it's much, much shorter than the half-life of azithromycin. Azithromycin half-life is 68 hours, right? It is in your system for a long time. What that means is for an individual who has gonorrhea, you treat them, they'll have both drugs up front, then the ceftriaxone goes away, and you have a very long tail of azithromycin. People who get gonorrhea tend to get gonorrhea, right? So if you then get reinfected, you'll be exposed to a subinhibitory dose of azithromycin, and I guess that is one of the drivers. The other possibility that we think may be playing a role here is that azithromycin is used for lots of things, right? So bystander selection for azithromycin in people who may have asymptomatic disease could also be driving resistance. And we have actually a paper looking at that relationship and suggesting that that's also something that's going on. So the use of selecting which two drugs to combine is really important, and being aware of how else they're used. So I would not take the experience with ceftriaxone and azithromycin as combination therapy really as a reason to dismiss combination therapy, and in fact would say that it's something we need to just be very deliberate about in choosing which two drugs to combine. I'm not sure that the microphone is on. Yeah. I can also repeat your question, so feel free to go ahead.
So it follows on the last question. I really like the idea of using combination therapy to work the development resistance, but I wonder if drug companies think of taking a step further, and instead of worrying about cross resistance, is there any drug designed to take advantage of cross lethality, so that if there's a mutation that induces resistance to one drug, it might induce particular susceptibility to another drug, so that if you use them in combination, whenever the organism developed a mutation to the first drug, it would be killed more readily by the second drug.
Yeah, so this concept in the field is known as collateral sensitivity. And that's absolutely, if people could figure out a way to do it, that would be ideal, right? So using them in combination in that way. Of course, it also then matters how you develop resistance to each of the individual drugs. And one of the challenges is, for each drug, there's often multiple pathways to resistance. So even though you might have collateral sensitivity for one pathway, there are often other choices, right? So we know there's target site mutations and efflux pumps and adjusting porins that allow the drugs in. So if you knew that there was only one way that a bug could become resistant and or lethal, to get around to lethality, you could have that kind of strategy. The problem is these Mother Nature and natural selection, pretty clever, and they figure out ways around it. And I think trying to optimize is still really the big challenge for us. And I'd point out that even though we don't really think about it, we have a drug combination we often use, and that's in Bactrim or trimethoprim sulfamethoxazole, right? These are two different drugs that get put together, both targeting different parts of the folate synthesis pathway, right? So, and we certainly have a history of combining drugs and being very, using them all the time. But so I think there's precedent for thinking about these kinds of things too.
Well, we're at the top of the hour, and so I want to thank you for an excellent presentation. As Hannah was commenting, there were lots of compliments online, and so people very much enjoyed it. A very topical conversation too about antimicrobial resistance in the modern era. Thank you a lot.